Welcome to Fun with ECGs. "30 seconds to look for evidence of ischemia." The changes on this ECG are a bit subtler. Particularly look at the anterior leads for abnormalities. So the rate is 54, sinus rhythm, normal axis, QRS duration is also normal. We have possible ST elevation in the inferolateral leads. I'd measure this at 0.5 millimeters. It's of uncertain significance. It certainly would be worthy of another ECG, but on its own isn't necessarily ischemia. But we have these abnormal peaked T waves in V2, 3 and V4, and these are very suspicious for hyperacute T waves. You might also want to check the potassium. You can see that the baseline is moving up and down a little bit. So here you might have said there's more than the 0.5 millimeter ST elevation, but if you adjust for the baseline, you can see actually it's only the 0.5 millimeter I've just described. And you can also see some artifact in these leads. Now, hyperacute T waves are a sign of myocardial infarction, but they are difficult to interpret and spot, and the absolutely essential thing here is to take a good clinical history and also to repeat the ECG. And the hyperacute T waves may be the first feature of ischemia developing. They may also be the feature that's resolving as ischemia resolves, and in fact this patient's ambulance crew ECG had marked widespread ST elevation, which cleared up by the time the patient arrived in hospital and had a repeat ECG done and was pain-free at that point. So hyperacute T waves are an early sign of STEMI. Look for ischemia and check other ECGs and expect there to be rapid evolution. And this sort of a patient needs to be urgently managed as per a STEMI by sending them straight to the cath lab. If you only had the hyperacute T waves, we couldn't thrombolize that. It doesn't meet criteria, but they should be treated otherwise if you have access to a cath lab as if they're a STEMI. Thanks for watching.